We will move on to the next panel. I'd like to thank all the speakers who presented papers in this interesting panel. You can send your questions online, and the doctors will answer all your questions one by one. The interpreters wonder when will that happen. Mrs. Giannaki Konstantinou is the General Secretary of our association, will moderate the transplant panel. I invite the members of the panel to come here.
We'd like to welcome Mr. Tsagaris, who is a professor of pulmonology, who is at the IKON Athens. He is responsible for the transplant center in the Onassion Center, and we'd like to thank him here for being here with us today. The transplants are really important for cystic fibrosis, for those who cannot benefit from the treatment. So, we are all ears, Doctor. First and foremost, I'd like to thank on behalf of the entire team for the invitation. It is indeed a great honor and a great joy to stand by you. We are always with you on a daily basis, and we consider it an honor to be able to participate in your struggle and fight. But as you can understand, sometimes things don't work as we wish, and we might need to move on to a transplant. Transplants in cystic fibrosis is a very frequent indication for, well, you can see here, cystic fibrosis is a very common indication. And these data reflect the situation before the advent of the new treatment that has radically changed the picture. There's a concern in the area to see as to whether we will have in the future referrals at a bigger age with much more complicated problems. So, if we are to have a good lung transplant program, we need to set this as a priority. Of course, it is your own priority. We understand this. Transplant activities in lung transplants in Greece counts more than 32 years. And I see that your association celebrates its 40th year. However, lung transplant is this transplant that is the most complicated of transplants. For this reason, many countries did not have their own transplants program. Even now in the Balkans, it's Greece, Slovenia, and Croatia who have transplant programs. As you know, throughout the previous decades, everyone would have to travel to Vienna. There was no other possibility. And thank God there was a significant number of patients who benefited from the operations in Vienna. You see that 70 or 80% of Greek patients who received transplants were young people with cystic fibrosis. But as of 2015, we knew that things would be different, and we had to have our own forces. So there was a Greek national program for lung transplants. This was not only the case for Greece, but for all European countries. So there was this program by the Onassis Foundation to train Greek doctors. There was this care by the states to create this program. And in fact, this initially started out by virtue of the government's gazette that you see here. The first transplants took place in 2020. Right now, we have performed 29 such transplants, of which 4 pertain to cystic fibrosis patients. So, lung transplant is a really difficult transplant. When colleagues from other organs see that the median survivals are such, they're always surprised. Cystic fibrosis, due to age, is an entity which has the best survival rates thanks to age of patients, but we can in no case claim that we are pleased with a 10-year survival rate. I'm talking about median survival rate globally. What is important and needs to be clear is that, well, this is from the heart transplant program. In fact, it's the same message. The right window. There's a specific golden window. Special practices need to refer patients with the consent of patients and associations. It is important. It is important for patients to go to the proper centers. Literature tells us when it's the most appropriate time for patients to be referred and to be included in the list. This plays a very important part if we are to improve the final outcome. Matching pertains to the size of the thorax and the blood group. This too should be taken into consideration in a country with a low number of donors, such as Greece. And another thing that is pertinent is what you see here. In transplants, the donor age and the recipient age, as well as volume of the center, is really important. So, we will need your own help vis-à-vis the association. Who have been the donors? Attikon Hospital and Nicosia Hospital have actually provided half of the number of lungs transplanted in Greece. You can see the contribution of all hospitals in this effort. Some definitely show that there's room for improvement, and this is the donors overall in Greece in the past 5 years. Why do I show you this slide? This all view that organ donation is not supported by society is absolutely wrong. What we've been able to show in Attikon Hospital, it's at the poor neighborhoods of Athens, is that when there's a good organization, it's clear that the Greeks are in favor of organ donation, and rates are comparable to the European ones. So it's a system that needs to be improved. Now, this year we have 84 donors. You can understand that we won't be able to reach our peak figures in 2005, 2008, etc. But there seems to be improvement as of last year. There's been a great effort and significant action undertaken both by the state as well as by the Onassis Foundation and the new transplant center, the new legal framework. Everyone needs to coordinate if we are to improve this, because in fact what we see in this slide is the following. Every hospital can have donors. It's not the old perception that we're talking about car crash victims. 85% of donors come from patients being hospitalized in general hospitals. So to conclude with, all those heading the program are going to give us the details on the efforts that we're undertaking. And I'd like to thank you once again for the invitation, to wish you to be able to walk with us this difficult path, and I wish you nice holidays. Thank you.
Thank Thank you very much, Mr. Tsagaris. We will now move on to the recording message of Mr. Chamogeorgakis. He is the director at the Cardiovascular Ward. He is responsible for heart, lung transplant and mechanical support at the Onasios Center. Can we put on the video? Hello, thank you very much for the invitation from the Association of Cystic Fibrosis Greece. I salute the conference of the Pan-Hellenic Association of Cystic Fibrosis. My name is Themis Chamogeorgakis. I am a transplant surgeon. Recently, I returned to Greece recently. Lung transplants at the moment in Greece are underway. We have made a third effort to restart the program, and we've performed since 2020 at least 20 transplants, which include cystic fibrosis patients. 11 transplants overall last year. This year, 10. The forecasts will be 15 to 20. We would like to double the number of lung transplants and achieve better results. Survival, as you know, in transplanted lungs is not as good as with heart transplants. And every new program takes a lot of effort in order to yield good results. At the moment, we are 70% successful, and hopefully we will improve. In regard to technical matters, for a lung transplant, a double lung transplant in cystic fibrosis patients, it is the same more or less as with other patients. The differences for this category of patients is that they are usually younger, and this makes us more sensitive. It's at the limits of pediatric transplant, so the responsibility is even greater for transplanted children. Of course, the younger the patient, the more the reserves and the odds are better for a good prognosis, and we are happy about that. The organism is stronger. Despite the many infections suffered by cystic fibrosis patients. Another good thing is that there is a drug which delays transplant, because transplant is a last resort solution for a respiratory failure. Now, I'm coming to technical matters. Beyond the young age, things are more or less the same. If you can find a donor, if a donor is if an appropriate donor is identified, the appropriateness is judged on the basis of anthropometric elements, matching criteria between donor and receiver. There are two teams also, the harvest team and the team which is in communication with the donor and waits and places the transplant, the graft. The harvesting is carried out according to a specific technique. It's not relevant for this conference. I don't need to go into the technical details. The recipient is being prepared The patient must be prepared by the team, must be opened, the surgical incision must be carried out, the lungs have to be prepared in order to avoid wasting precious time. And as soon as the graft arrives, we can immediately proceed to removing the recipient's lung and graft the donor's lung. This is always by definition a double transplant. We cannot leave an infectious lung behind, so these patients are subject to double transplant. Lately, we have addressed some patients and they have done well, and don't forget the female patient who was in ECMO for 3 months or more, but despite the adverse conditions, she survived and she was released after a double transplant. One commentary for donors. The number of donors in Greece in the last couple of years was doubled, and this is due to the 7 coordinators who were placed in the big hospitals. They do a great job. We have now we receive many calls from possible donors. Hopefully, the same enthusiasm will go on in the future, and the Greek program will be a strong European program with good results and a big number of transplants. Thank you once again for the kind invitation, and I hope we will be able to communicate often. Goodbye.
Thank you very much, Mr. Chamogerakis. We move on to Mr. Theodoropoulos Fotis, who is the Registrar of Pulmonology at the National Transplant Center. Thank you. Yes, now you can hear me. Okay, excellent. Thank you. Thank you for the invitation. It's an honor for me to be attending your event to celebrate the 40 years of your association and to discuss about transplants. Thank you for devoting one hello of the specific topic. Although the probability is lower for a need of transplant, one might say that you might exchange one condition over another. I will disagree to that because we have with us here patients who have received transplants. So, I have quite a few transparencies and I will take more time. Now, lung transplant is a definite solution and the problem that unfortunately is not seen only on the lung, but we aim at changing the main organ that leads to a reduction of the life expectancy through a double lung transplant, which is the most indicated solution. We expect for the patient to reach 60 to 70% of everyone. The peak can be reached to the 6th or to 9th month. The second half of the year post-transplant, the patient won't have hyperoxygenemia and hypercapnia. These are quite frequent in malnourished patients with a poor performance status. Now, the transplant care. This is a very complicated mechanism. There needs to be a well-tuned Swiss watch in operation here. And even if we have a cog that's not working well, the whole system will fail. And time will tell. Here, of course, we have the patient coming in with the cooperation, the supportive environment, and other specialties. Be them in non-nursing hospital or in Atticon hospital, in care, etc. I won't refer to the role of each specialty because this would obliged to account for 50 or 60 different specialties. This is a government gazette showing how our program works, evaluation at our Attikon Hospital, the perioperative care at Onasion, and post-operative treatment in the first 6 months, again at the Onasion Center. And always in cooperation with Attikon, and there's a transition for the follow-up to Attikon Hospital. In Attikon Hospital follow-up, we also have Professor Jaks from Austria. 44 patients who had received transplants in Austria are alive and are followed up. Yes, 9.1 years, etc. It does not sound like a lot when we talk about median average. Median expectancy or survival. This is the example of a patient. Most of you know her. She is alive 21 years post-transplant, and I too am familiar with patients' cases in Germany who have survived more than 20 years, and there has also been a repeat transplant, and the patient is alive for the past 29 years. The patient is functional. She has never reached what was expected. FEV1 42%. She's working. She is moving, etc. She has this BOS disease, that is the chronic dysfunction of the operation of the transplant. A timeline of complications following transplant, lung transplant. Through time, the first 6 months, surgical problems, infections, either acquired at the hospital or in the unit, etc. Then we have cellular rejection, acute cellular rejection. This is this is in like the end of life, but it's not so. The complications of the immediate post-operative care. In my view, knowledge is power. We should never underestimate patients. We should not deprive them of information that is important. No, definitely targeted IV antibiotics on the basis of the antibiograms of both the donor as well as the recipient. If the recipient comes from a Greek ICU, we're talking about fungal antibiotics, etc., aspergillus. We'll have to provide double targeted treatment, inhaled and IV. High incidence of gastroparesis. This is to be expected. This is a side effect of medication. Gastric motility problems, difficulties in digestion, etc. Malabsorption. The patients are in high need of suppressive treatment, analgesics. DOS is an important problem that we should not underestimate, not only in patients with a positive history in the past, but even in patients without a history. We need to be cautious with regard to nutrition, and bronchoscopy plays an important part for the identification and timely diagnosis of all these three entities. Surgical problems, infections, and acute rejection. Regular bronchoscopies. Patients who have to receive transplants need to accept this. In the first 4 weeks, once or twice a week bronchoscopy, sedated, and then at regular intervals for surveillance to identify problems that might evolve and that will be incorrigible afterwards. There's a high rate of subacute acute rejections. This appears to be higher rate in cystic fibrosis patients. So one of them, at least, will have one episode of acute rejection. This can be treated without leaving any residue. And of course, the identification of pathogens here. Acute cellular rejection might be non-specific. It might resemble simple infection with flu-like symptoms. We need to administer corticosteroids. You can see. And there's also the asthma monitor or the portable spirometer. Abroad, this is a must. All patients do it. In Greece, there's no such culture yet. We try to establish it. Several devices that are prescribed for cystic fibrosis. You can see the curve. The asthma monitor drops from 50 to 20%. Unfortunately, we were notified with a month delay. We acted, we administered cortisol, there was improvement, but you see that there is a falling tendency, which might be due to the delayed management. There was a chronic dysfunction installed afterwards. The longer the years, the more the patients tend to neglect the use of asthma monitor or spirometry. This is a problem. It has an impact on survival. There are many different studies, showing you one here. If we adhere to 80% of the instructions, we have a higher and better results. We talk about a regular and accurate administration of drugs, a nutrition plan, an exercise plan, preventive tests, and of course avoidance of smoking. I will refer to drug toxicity. This is really important. I like this study. This comes from Austria, with patients who might also be Greek patients who have received their lung transplant. Would you decide again for the transplant? 92% of them said yes. The main problem of these patients is the immunosuppression side effects. This is something that we cannot avoid. We need to avoid rejection, and we need to balance between rejection risk and infections. A characteristic example of the medications post-transplant. Tacrolimus. Nephrotoxicity, hypertension, hyperlipidemia, diabetes, trauma. Celcept might lead to leukopenias, anorexia, gastritis. Of course, by changing and switching the medication, this can be improved, and teratogenic action in case of pregnancy. Cortisol, then known side effects and complications. How much time do I have left? 2 minutes. A very quick reference to the BOS and CLAD. We haven't improved greatly in the past 10 to 20 years. This is destiny, and we can't get rid of that. Well, we have a bit better results vis-a-vis chronic rejection, but in 5 years' time, 50% of patients will be in chronic rejection. Of course, the pulmonary function pertains to the patient, the comorbidities, etc. I refer to some factors that might lead to BOS. That could be colonization, the fact that Pseudomonas persists. This might have to do with the reservoir of the upper respiratory tract that hasn't been taken care of as it should. Chronic rhinitis, sinusitis, this is not treated as it should. Moreover, gastroesophageal reflux. Now, I'm talking about community-acquired respiratory viruses, other viral infections that might affect the transplant. We need to know on time. The speaker speaks at extremely quick speeds. So each solution might stimulate a chronic or an acute rejection. All these factors are modifiable by the patient. What can we do? In the case of both, our hands are not tied. We can switch to Zithromax. We can have ECP, extracorporeal photopheresis. Already we have 4 patients at Athens Hospital treated with very good results. Unfortunately, results show us that 15% of patients with BOS are already at stage 3, very low function, and 15% of the baseline. This is a problem that can be solved with frequent visits to the doctors and with the asthma monitor that patients themselves check. If they wait to come to the hospital, you can see the condition in which they will reach the hospital. You can see what this ends with. ECP, etc., might lead to stabilization. Definitely there is a falling trend, but you can see the difference in the curve. The sooner we act, the better. We might be led to dyspnea, and we might need palliative care or repeat transplant. Let me tell you a few things about malignancy. The second cause of mortality after rejection, skin melanoma, is much higher risk. You need to avoid the sun, get sun protection. Once a year you go to the dermatologist. It's better to prevent than to cure. Intestinal cancer, 8 times higher probability. A very good colonoscopy for screening, etc. We provide informative leaflets to our transplanted patients. Diabetes mellitus, 1/4 of patients suffer from that before the transplant, and the incidence rises up to 50%. We'll see how things go after the first 3 months of good regulation of sugar is important, well-regulated sugar, and compliance. We opt for insulins and not metformin. Osteoporosis, 47% prevalence before transplant, 73% post-transplant. Timely diagnosis, substitution with vitamin D, biphosphonates, and of course the renal failure. And I'd like to refer to psychiatric diseases as well. There's no special culture in Greek population vis-a-vis this path. Depression, stress disorders, very frequent. In the first post-op years, things go well, but as soon as the problems start, well, it's increased. Maybe medication is needed, supportive environment, follow-up by specialists, and the last slide, occupation or work. Many would ask me, can I work? What kind of job can I do? These are data from the International Registry. So in 5 years post-transplant, 40% of patients are not working, another 20% keeps on working. I could refer to Protestant views as described by Max Weber. In Germany, when you do something and you are offered something by society, the society needs to get get something back. Aside from that, which works in Germany, let me tell you that work is something that allows us to achieve self-fulfillment, allows us to feel productive, the feeling that we offer something, we move, etc. We support this. And of course, we can adjust to that. Thank you for your attention. To have access to the Hellenic Transplants Organization to donate your organs. So I think that this has helped us a lot. Thank you.
Thank you very much. Follow-up is very important. As important is the first step to the procedure, equally important is the follow-up. It is much more imperative compared to drugs and compliance prior to transplant. It is indicative. Patients' compliance is always context-related. A good management of the disease before is indicative of how it will happen afterwards. There are negative and positive examples, and we are often surprised. For instance, South European, Greek and Turkish examples were not complying enough. We are here to provide information. We need to explain. We need to go hand in hand. We are available 24 hours per day. Perfect. Now we give the floor to Manos Himonis. He is a coordinator of transplant at the Onasio Cardiosurgery. Well, before Manos takes the floor, I'd like to stress that we are fortunate because we started before the COVID pandemic. You realize what would have happened if our country had not a program during the COVID and people could not move. The dozens of patients would have been unable to move. It is already difficult for us due to our geographical situation. So the role of coordinators, the role of compliance is something that we need to stress to all of you. Lung transplant is not a mere surgery. It is a comprehensive package and we are all stakeholders. Manos will be coordinating all that. Good afternoon. Thank you for the invitation. Okay, until your presentation comes up, I don't know, I can proceed. I have notes. What is the role of the coordinator? Transplant is the only treatment in a terminal organ failure. It is the only hope for survival and improvement of quality of life. The success of a transplant depends on the number of grafts and the willingness of society to donate. Without donors, there are no organs, and without organs, there are no transplants. Context: National Organization of Transplant, coordinator, the central coordinator, local coordinator, technical coordinator, the central coordinator. It provides competencies and duties to promote the national program, cooperates directly with local and clinical cooperators in organizing the procedure for a safe distribution of grafts, promotes donation through communication structures and programs, supports research, lifelong training and cooperation with abroad. Local coordinator is the link in between the organization for transplant and hospitals. Manages potential donors, approaches families, informs families about cerebral death and the possibility of donation, obtains consent, helps with harvesting, informs hospitals for the donation. Technical coordinator, projects, patients, controls and checks, puts in the recipient in the registry, monitors the recipient, mobilizes and organizes transplant process, trains and monitors the patient throughout their lives. The aim is it is a professional insurance of caregiving in all stages of the procedure. It is the link with patients, medical services, nursing services, and central services. Pre-transplant stage: admittance, planning, organization, tests, daily visits, control of results, information training, organizing the selection committee, informing patients for choices, waiting lists, entering recipients, 24-hour monitoring of patients, external coverage on a daily basis, transplant procedure, cooperation over the telephone, mobilization of team, organization of teams, organization of transport, control of materials, drugs. In case of inappropriateness, non-matching, interruption of the procedure. After the transplant, organization, admittance, results, information of patients about their clinical situation, drugs, treatments, monitoring through external clinics, interruption of drugs if thought necessary, and many others that the speaker is going over very fast. Thank you very much. For sure, what I retain, Mr. Tsagaris, is a hopeful message. We have grafts. We were under the impression that we didn't have grafts and that Greece was ranking very low in the list, but it's not like that. Well, listen, things are never black or white. Things are always gray. When you compare oneself to Belgium, which has the same population as Greece and performs 100 lung transplants per year, our 10 lung transplants may look like nothing, but our 10 transplants are many more than those performed in Romania and Bulgaria. So what one needs to look at is in what extent we as a system prioritizes resources. For instance, things like transplants need to receive the necessary resources. If you listen to what Manos said, you realize how many more resources we need in order to have things run smoothly, how resources should be given to a donation story. And there are all these cogs, as Fotis showed. As a society, we make an investment, 100 million in Onation only. If the remaining cogs are not working properly, this investment will be problematic. Therefore, there is a lot of work to be done by ourselves, by yourselves, so that in a competitive way, because the resources that we are claiming will be taken from somebody else. Unfortunately, this is how it is. We need to get the maximum resources, and with very strict accountability, these resources have to be put to good use. Any questions from the audience to our doctors? Mrs. Hadjiagoru. Questions should be to a microphone, otherwise you will not be getting the translation. Good day, congratulations. We're very glad with all this work that you have undertaken. We have experienced how things were before, and we have experienced how things are today. So we are filled with enthusiasm. What about pediatrics? Do we have any possibilities? What is the situation there? Well, look, there is a prediction so that the transplant center at Onation, and this is a priority. We organized a master class with all transplant units. This is a priority of the system. We have to cover pediatric cases in terms of lung transplant and in terms of heart transplant. There is a shortage there. As you know, young patients, in fact, are referred to Italy at the moment, with which we have a transborder, transnational agreement. You understand that in order to build a program, this is not happening from one day to the next. It has to be built laboriously with a lot of organization. Professor Boletis, who is the locomotive of this effort in Greece, from what he presented, he has assigned priority to our transplant center at Onasio to cover these two significant priorities. To be honest, we are very enthusiastic about the new drugs, the new treatments, and we hope that a number of referrals will be really small. Well, the truth is that pediatric patients with cystic fibrosis will not need. But as pneumologists, we follow children with interstitial pulmonary disease. We have a patient of 4 years old who developed respiratory failure and is intubated to a respirator. It's very rare, unfortunately, but we have these cases with interstitial disease. Yes, they are very rare cases. We are monitoring supply throughout Europe. Pediatric grafts are very rare, and the pediatric community has to be involved a bit in donation. The good example of Attikon Hospital with adults is Iliadis in Patras. Athens and Thessaloniki need to be active with donations in order to have grafts. Without grafts, as Manos and Fotis said, of course, nothing will happen. You realize that the volume of transplants is strictly connected to the outcomes. This is true for all programs. The more things we do, the better we become, not only in surgical terms, but in the whole spectrum of management factors. And this is a social need. The little child that you say needs to have access to a good system. I totally agree. Thank you very much. Any other questions from the patients' organizations? Do we have a transplanted patient among us today? The photographs have just arrived.
Εγώ δεν έχω...
Ήρθα στο πάνελ τελικά.
I came to the panel, finally. I don't have a question. I just wanted to say thank you, because we all know how difficult procedure a transplant is. From the beginning to the end, prior to the surgery, you have the pre-operational, the pre-op control, during, after. Thank you very much. Before transplants in Greece, our first priority was to secure this gift of life. We made a lot of efforts to sign the agreement with Vienna, and now that we do have transplants performed in Greece, we are here to provide every possible assistance. We also want to thank you, and we would like to thank the very brave people who in the most difficult time of their lives think about you, the families of the donors who truly donate life to many people at a very difficult moment for them. We are all grateful and thank them.
Να ευχαριστήσω και εγώ με τη σειρά μου όλους.
Let me also thank you all. Thank you for your participation. We will interrupt for lunch. You will have to go up the staircase, and there is also a stand with wares, products that you can buy for the association. Our association needs your support. We will have a half-an-hour break, and then we will present a book that our team has produced, a book for our young patients. Thank you.
On the outside, you might just see a happy child playing. A child excited to explore the world. You might not see a child with cystic fibrosis until you start to see its symptoms as they progress over time. But if you could see inside, you would see the damage taking place. Even before you see the symptoms progress and become visible on the outside. Don't wait to see cystic fibrosis.